This episode of Distraction is sponsored by Landmark College. Try their free comparison tool for colleges with learning disability support at lcdistraction.org. Landmark College. Learn your way. Succeed uniquely.
I tell parents that this is going to be more of a marathon as opposed to a sprint. So I want them to pace themselves too. Parents have to take care of themselves so that they can take better care of their kids. It's a classic adage in child psychiatry that you need to put on. It's similar to flying an airplane when they talk to you about the potential in case of loss of oxygen. Put your mask on first and then your child. And we say the same for most of the conditions in child psychiatry. Parents need to take care of themselves because the parents are going to be taking care of the kids.
Hello, this is Dr. Ned Hallowell with another episode of Distraction. Today I'm really excited to welcome my friend and colleague, Dr. Tim Willens, one of the leading voices in the field of psychiatry and more specifically child psychiatry. Tim is the chief of the Division of Child Psychiatry at Mass General Hospital, of course one of the world's greatest hospitals, where he is associate professor of psychiatry and really one of the nation's leading teachers. He does many seminars and serves on all kinds of committees and does his best to teach the rest of us about what's going on in child psychiatry, a burgeoning field where more and more is being learned, and there just aren't enough child psychiatrists to go around. It's one of the most underpopulated of all medical specialties, which is a shame because the supply of children is not running low, but the supply of child psychiatrists is indeed. So Tim kindly took time out of his busy schedule to come on our podcast to try to inform our listeners about various topics related to children and their needs in the realm of mental health. Why don't we start with a topic near and dear to both of our hearts, namely ADHD. What do you think the average person needs to know and doesn't know, Tim?
Well, first of all, Ned, thank you so much for having me on your podcast, and thank you for your kind words. And I want to reciprocally say that it's always an honor to be on the stage, or in this case on the podcast with you, somebody who's really been a staunch advocate around education and clarification around some of the misviews about ADHD in the field. So I thank you very much.
Thank you.
There's a lot going on with ADHD in terms of many of the different areas associated with ADHD. And I think probably some of the hottest things going on with ADHD right now is really understanding sort of different areas. Number one is the long-term course of ADHD. I think that we're really beginning to appreciate, that this is a long-standing disorder in a large proportion of individuals who are younger who are going into adulthood. So I'd say that's one. The other areas that I think there's intense research and clinical understanding right now is on what the sort of standard rubric of called executive functioning, sort of the secretary of the brain's control of both cognition, how you think, but also emotion. So I would say executive functioning is another area that really is a hot ticket item. And then I also think treatment is always going to be there. What do you do? What do you do from a psychotherapy, psychosocial perspective? What do you do? What about these online, kind of cognitive training? And there's some recent work with some new video game-like interactions for kids. And then, of course, the standby medications. What's going on in the medication field for both stimulants and non-stimulants? So, I'm giving you sort of a grab bag here to choose from. But I would say those are three areas that have sort of international attention right now.
Mm-hmm. So for a parent out there who thinks their child might have ADHD, what's the most reliable way to get a diagnosis?
That's a great question. There's a number of, I'm going to start with the punchline short answer, and that is a good clinical interview. And
Yes.
That is to sit with somebody, a pediatrician, child psychologist, psychiatrist, somebody, a nurse practitioner who's trained in this area, a practitioner who has experience working with kids, a clinician or a practitioner who has experience with ADHD, and somebody who's going to go through and ask not only the questions that would compromise ADHD, but also get a better sense of functioning of the kid, and then a real thorough examination of the child in terms of their environment, in terms of their family, their biological risk factors, other medical conditions, and other kinds of just their general functioning with other peers, et cetera. It's really this sort of constellation of symptoms and understanding what are core ADHD symptoms and what are other things that could mimic ADHD, including stressors out there that may not at all be ADHD, other psychiatric disorders, anxiety, mood, or things going on in the classroom. You may have a child that has a lot of learning issues that are not being addressed, and it can look a lot like ADHD and may, in fact, be ADHD with learning problems, or it may just be the learning problems. So I think it starts with a clinical diagnosis. Many of the constituents of a good diagnosis now utilize rating scales. There's a whole host of different rating scales, and these scales are done by parents reporting on their children if they're younger, parents reporting on their adolescents, and adolescents reporting on themselves if they're older, and then often schools reporting on the kids so that you get a sense of what the parents see, what the schools see, and what the kids see. And then lastly, and I put this more in the marginalized area because I think there's still a lot of question and debate going on, and that are these these electronic diagnostic systems. They're reliant largely on derivatives of neuropsychological testing that they can do online that can evaluate more objectively how a child performs on certain tasks of attention, focus, memory, areas that we know are often awry in ADHD, and that's another sort of way to triangulate the diagnosis.
Mm-hmm. And once you have a diagnosis, what would you say are the basics of a solid treatment plan?
I really think that really understanding, first of all, understanding the disorder, really, education, familiarizing yourself if you're a parent of a kid is what does it look like? What's the course of this disorder in its untreated state? What happens if you treat it? But also understanding, what it is. Where does it live in the brain? What are some of the symptoms, which means the things that it's causing in the kid? And then what are some approaches that you can take with this disorder that are very, family-friendly and child-friendly that are not just running and going to medication, really educating yourself on the need for structure, the need for routine, clear, precise messaging, and also sort of an empathy for the kid. This is a kid that's probably not going to be able to sit and do their homework without some type of supervision or structure and routine. And it's really not the kid's fault. It's not that the kid doesn't want to do well. It's just kid can't do well in that. But so really having a thorough understanding of the disorder. And then I think you have to take a look at what needs to be done educationally. The most common presenting reasons for ADHD in children continues to be education and underachievement academically or some behavioral symptoms. That is acting out, the class clown, moving around, shifting, not being able to stay seated, having this restlessness, getting up and going to the bathroom a million times during the day. Those types of symptoms, as well as the inability to pay attention, follow through on tasks, the inability to get assignments down, problems completing tests, et cetera, that you have to sort of understand that in the educational setting and try to work with the school system to mitigate some of that using structure and focus and ways that they're really good at in terms of helping that individual student perform well independent of medication status. And then I do think that given guidelines from the American Academy of Pediatrics and Child and Adolescent Psychiatry, two professional societies that care a lot about kids and kids with ADHD, that you think seriously about considering medications if there's moderate or greater severity associated with the ADHD, and that would be done with by somebody who has experience with medications and understands the various roles. So I think it's probably all of the above that's going to give you the best outcomes. And the other thing I'll say is it isn't a one-shot deal. You do your best assessment and plan to get kids started down this path. But things change. Kids evolve. Certain things work better than other things, and there's going to be a lot of adjustments for all of the things I've just mentioned and others as the child progresses and as you start to learn more about the kid and their ADHD and how that's impacting their day-to-day interactions with the world.
Yeah, it's a chronic condition, and the treatment plan has to change over time.
It is, and I think it's an important component that what you just said, it's a chronic condition, and as such, it's going to be there for a while. And I think people have to, I tell parents that this is going to be more of a marathon as opposed to a sprint. So I want them to pace themselves too. Parents have to take care of themselves so that they can take better care of their kids. It's a classic adage in child psychiatry that you need to put on. It's similar to flying an airplane when they talk to you about the potential in case of loss of oxygen. Put your mask on first and then your child. And we say the same for most of the conditions in child psychiatry. Parents need to take care of themselves because the parents are going to be taking care of the kids. And we want them to think about these conditions as chronic. I mean, some kids are going to get better, and that's great. But if we plan for the long haul, parents will be more able to be there for their kid and not really tire or poop out too early and not be able to be there for their kids.
Yeah, my old teacher, Tom Guttal, used to say to us, never worry alone. And I think a lot of what we can do with parents is worry with them, because it's this condition can give parents a lot to worry about. And it
can, and there's a lot of support groups that are available for ADHD that I think are really helpful in that sense. Two of them are Add-In and Chad, but there are others. And some of these are online, so you can online chat, you can go to actual meetings. And in my experience working with parents is that I asked each of them to get involved with some support group for a period of time, and it really is salve on the wound, so to speak. They feel like there's other people that are going through this. They feel more comfortable. They usually meet other people locally who they can talk to who are struggling also. And there's nothing, I think, more important to these parents than some level of empathy.
Absolutely. You mentioned medication, and sometimes people ask me, do you believe in medication? And my answer is it's not a religious principle. It's a tool that can be helpful or not. And you wrote one of the best books on medication. What's the title? Yeah,
it's not, I would say, the most creative title in the world. It's called Straight Talk About Psychiatric Meds for Kids. And thank you for that. I wrote the book because I see a lot of patients in my own clinical practice here at Mass General, and I always felt like I never had the time to get through all of the things that I would want to know if I were a parent of a kid who's receiving medication. So it's really sort of a parent's guide based on that, really kind of walking you through what are the major disorders in all of child psychiatry. It's not a just ADHD book.
Right.
And then what are the disorders so you know diagnostically. And that actually across all ADHD, including across all child psychiatry and ADHD, is really critical. What is wrong with your kid? Before you treat, what is going on? And having a good diagnostic hypothesis is the first step. And then from that, what are the treatments that might be useful for your child? And that includes all different types of treatments. And which ones are demonstrated to be effective? And of those that are demonstrated to be effective, if it's medications, that's then where we sort of derivate the second and third parts of the book are more focused on the medicines and their when they work, when they don't work, and side effects, which are, something that you have to really seriously consider.
And as a parent, to get that straight talk is not easy to do, and Tim's book is easily the best one for getting exactly that. Well, so let's move from ADHD to another really common and difficult one, mainly in adolescents and young adults, namely substance use. And I just took Mass General's course that Tim was a key part of on substance use disorders. And first of all, I love the fact it's framed now as substance use disorder as opposed to addiction. But want to make a few comments about that and how common it is in teenagers and young adults? Absolutely.
So substance use disorders, as you correctly report there, it's been sort of relabeled from addiction and substance abuse, which has a pejorative sense. And I just want to start by saying that words do matter. There's actually been studies that show if you approach a practitioner or a family and talk about substance abuse, they're a lot less likely to see it as a chronic disorder that requires treatment. They see it more as a moral or moral turpitude of some sort, that it's not a medical condition, as opposed to substance use disorders where there's now empathy from the person sitting across saying, wow, that is something that could be amenable to intervention and treatment, and this is a medical condition that requires treatment. So substance use disorder, there's a lot in words. Just the reason we're interested in children and young people is because 50%, half of cases of substance use disorders onset before the age of 18 years, and 80%, over three-quarters, onsets before the age of 24. So, as you were saying about adolescents and young adults, that's where substance use disorders are onsetting. And the problem is, if you say substance use disorders, a lot of people think of 40 and 50-year-olds. And by that time, you've had 20-plus years of damage caused by the disorder. And what we're really trying to do is say, look, let's identify unhealthy substance use and substance use disorders very early. And if you do that, by the way, about 10% of adolescents have a substance use disorder, equally split between drug use disorders such as marijuana and alcohol. And if you wait and don't do anything, anywhere from 20 to 25% of adults will have a substance use disorder. Now, those are lifetime prevalence. That means that it's sometime during your life, not necessarily right in front of you, but sometime in your life. So it is a relatively common occurrence, and I don't think anybody listening to this podcast doesn't either have a family member or know of a good friend or family member that has suffered from a substance use disorder. So it is, in our department we have a saying, no family goes untouched, and I think that I'm fair to say that no family goes untouched when it comes to substance use disorders.
Yes. What is the current treatment?
So the treatment is, again, at first getting a diagnosis what it is. I think it's important with substance use also to understand what's going on in the environment. And then, certainly as a psychiatrist, I'm very interested in what other psychiatric issues, mental health or behavioral health issues does this person have? Are they self-medicating a depression, ADHD? Do they have a severe anxiety or panic disorder, and they're using around that? And then, of course, you want to understand medically what's going on. Unfortunately, individuals can get medical conditions, heart valve infections and hepatitis C, et cetera, and liver problems based on it, and a whole host of other things. The treatments really for substance use disorder are helping the person engage in treatment. So we used to think you have to have come across the threshold where you are highly motivated to treat for treatment and you've hit rock bottom, and now treatment starts. And now we realize, in fact, if a person will sit across from you for any reason and you can help motivate them, you can help them with their own words and understanding of the disorder start to engage in treatment, that's a good thing. We find better outcomes. First of all, we can take people who haven't hit rock bottom, who are usually suffering from some type of functional problem, such as money problems or missing work or having problems in school, being sick from this, family problems, relationship problems. And you can just use that as a toehold to get them connected to therapies and engage in their treatment. We still would recommend that the vast majority of substance use disorders, for alcohol use and marijuana and others, that therapies can be very helpful, and that therapy can be either group types of therapy or individual. Self-help, AA, NA can work really well. Again, just remembering people that you can go to these meetings. It's best if you know somebody who's going to one of these meetings. They can take you. It's called facilitated attendance, and it works much better. But if you go to AA and A and you use them, they're cost-effective. They work really well. But there's other treatments for certain addictions, such as if you have opioid use disorders, if you're using heroin or fentanyl or prescription painkillers. Usually you're going to have to be put on a medication to help you calm your brain's sort of reaction to the opioids. And then you can engage in other types of therapy and over time wean off of those treatments. We know that those treatments save lives. Just being on a medication treatment for opioid use disorder reduces the likelihood for a fatal overdose by 50%. And for most of the other substance use disorders, we have medication treatments that maybe help reduce the urges and cravings, and along with talk therapies and group attendance, most
even for
better.
alcohol, right, Tim? Even for alcohol,
even for
medication?
alcohol in particular, we have a few treatments that really can help people cut their desire to use, and that plus attendance at groups and things really can help people with alcohol use disorder. It's actually a positive prognosis disorder. That is, people do well with treatment, actually.
So you don't have to rely on willpower alone.
Yeah, and that willpower issue, it's great if you have it, but if you had it, you probably wouldn't still be drinking. So by definition of the disorder, you don't have it there. And what we want to say is we want to help you with your willpower by improving the part of the brain that provides the executive oversight to which is sort of dampens, I want to drink. It helps improve that. And also reduce the reward centers of the brain, largely through medicines that help cut down that I got to have alcohol, I got to have pot, I got to have whatever drug. And that's often a medication sort of treatment. So we see them as complementary.
That's wonderful. Let's hit one more topic, which is another big one, anxiety among children. Teachers tell me all the time kids are more worried than ever. Is this anxiety disorder, or is this just we're living in worried times?
And you've written very elegantly on this whole issue of anxiety, and it is a major consideration. And I think to answer your question, it's a little bit of both. That there's clearly settings that exacerbate and are pressure cookers to really bring out anxiety in kids. And then there's kids who have bona fide anxiety problems. And, anxiety comes in many forms. Again, it can create a lot of problems for kids. I call them the silent sufferers often, that people may not even appreciate how severely impaired somebody is or how they're suffering because of their anxiety.
Yeah, that silent suffering does a lot of damage, doesn't it?
It does. And often I hear the damage proximal to it when I'm talking to a kid, but a lot of times a parent brings a child in and says that my daughter or my son has got a lot of anxiety, and I know it because when I was a kid I had a lot of anxiety, and I really suffered with it. So I hear it from the parents who look at the kid and say, I get it, I know, I've had the same thing, I see it in my kid. It really kept me from doing a number of things I wish I would have done, or I had, physical symptoms I lived with, or I was stuck with things in my head, this obsessionality that is often associated with anxiety, worry, I panicked. So you hear it from the parents often who also can see it in their kids. But again, the good news, it's a good news story with anxiety. I think more and more we're talking about resiliency building in kids, which is sort of a general platform of improving kids' ability to deal with anxiety, as well as mood, by the way, but also anxiety. And then using, certain types of therapy that really are indicated. That really would be my first choice for anything that's more clinical. That is that it's not just going away with it, which includes derivations of like relaxation techniques, but cognitive behavioral approaches, which are very helpful for the kid to build skills around anxiety to help them deal with the most anxious situations, and over time, they call it desensitize them to that so that they can deal with that. And then again, distally down the way, there are medicines, there's a whole host of medicines that have been tested and shown safe and effective in this age group. But, again, I think there's a lot of things you can do for anxiety that really would help. And in terms of kind of what you started with, the pressure cooker situation, I think we have to be mindful of that. I think that's a bigger sociologic question that I'm not sure I have great answers for. Well,
I mean, I think just what you're doing is a great answer, just to providing information and education and, the never worry alone blanket that you're spreading around the country is terrific, Tim. I mean, it's And it's really good news that more and more research is being done, and the whole field of child psychiatry is growing, and certainly we need more child psychiatrists, and we need more information. And I think, the things like school shootings point up the need for greater mental health and prevention programs and identification. My big bugaboo is the epidemic of disconnection. I just think, we're living in society that's electronically super connected but interpersonally disconnected, and I think kids worrying a lot has to do with that. But what you're doing at Mass General is just fantastic. I'm just so impressed with the work all of you are doing. It's wonderful, and I can't thank you enough for coming on my little podcast. It's wonderful. Are there any last ideas, thoughts, points you want to share?
All I would say is thank you for continuing to educate people around it. I think, it's child psychiatry is in a little bit of a state tune. There's lots going on. Mm-hmm. And in the past, we were always criticized for not having enough empirically based data, which is, scientifically derived data to tell us what type of therapy you should use and what works for what. And it's kind of flipped now. So part of the issues we're struggling with is from an academic side is that there's a lot of data now. In fact, there's so much data. It's trying to keep that clear. So I think that's one of the areas. But I also think as the field moves forward, we're working with pediatrics to be more embedded, which means we're going to be working side by side and helping to teach pediatricians as we see individual cases. So don't be surprised that they're going to be doing more screening. If you take your kids into pediatrics offices, they're going to ask you more behavioral health questions. Yes. Don't be surprised if you identify something, if a pediatrician either says, why don't we think about treatment, or turns to somebody and says, there's somebody working right in our clinic. Do you mind if they were to chat with you? And I would say take that opportunity, because we know this is an issue. We know that there's not enough child people, but we're extending that by working with people in clinics to make it easier for families and for the pediatric practices. And so I'm very optimistic about behavioral health. I think it's in the discussion now for most people who take care of kids, people like yourself who talk about the care of kids. And I'm just reaching out to parents to say, hey, we're entering a new day where there's going to be more questions and more potential of availability of resources. Take advantage of it. Take advantage of it. If there's, God forbid, your kid is affected and by something you're not sure, reach out to your pediatrician, reach out to the care providers that are around you. We have a lot to offer.
You bet. Amen to that. Thanks a million. Dr. Tim Willens from Harvard Medical School and Massachusetts General Hospital. Thanks a million.
Thank you.
Well, my tremendous thanks to Dr. Tim Willens, truly one of the giants in child psychiatry today, from Mass General Hospital and Harvard Medical School, and also one of the really nice guys. He's as down-to-earth as he is smart. And his book, Straight Talk on Medications in Child Psychiatry, is a really excellent reference if you want to know about using medication in children. A really, really excellent resource for you, and a wonderful man. Really, I was really thrilled to have him on the show. So, that's it for another episode of Distraction. I've really grown to love this show. I hope you have too. Please send us your ideas for shows. We love having your suggestions. Send us questions, show ideas, comments to connect@distractionpodcast.com. That's connect@distractionpodcast.com. Or leave us a voicemail by calling 844-55-CONNECT. That's 844-55-CONNECT. Distraction is produced by Collisions, the podcast division of CRN International. Collisions, podcasts for curious people. Our producer is Sarah Gerton. Our sound engineer is Pat Keogh. And this episode was edited by Scott Person.